Klinheim, Haematology, Demystified.
So yeah, I was asking if this baby's cord blood's HPLC looks normal or abnormal for a newborn, and what were the answers?
Looks abnormal because hemoglobin A is totally absent and supposed to be
Hmm.
30%.
Yeah, 20 to 30%. And is
And
HbA2,
A2,
is that abnormal?
yes, supposed to be 0.3%.
Yeah, but it can be absent at birth, so that's fine. So the main abnormality is that there is no HbA and predominant is HbF, so it should be, as you say, 20 to 30%. So that's good. So what do we do next now for the baby? She is she's say 10 days old, 2 weeks old now, and we've got the cord blood back. We've got the patient's parents in the clinic. So what do we say we're going to do next now?
Watch for a few months.
Yeah, very good. Because they're likely to not run into any problems till 3 to 6 months of age. And meanwhile, we will send off genetics. Slides moving, yeah. So slides moving, right? So you should say
Yeah, they're
beat,
moving.
yeah. So it should say beta, yeah. So basically, genetics come back, and we have got a conclusive diagnosis of beta thalassemia, likely to be beta thalassemia major. No other genetic mutations found in any other genes, alpha or otherwise. Next,
Hussein, what is form we are sending for them?
sorry.
What are form we are sending for
Uh,
this?
I think I mentioned that in the last one. I think it's R92, and there's another one.
Hmm.
Yeah. Anyhow, so next steps. What do we do now? Somebody said monitor, and that is the right answer. So we monitor them at least monthly. And baby is still a baby. Yeah, we will refer them to the specialist hemoglobinopathy team in an MDT setting with a peds hematologist and other pediatricians and things, and the rest of the team, so CNSs, etc. Um, and this is going to be managed in an HCC, which is a hemoglobinopathy coordinating center. We're going to give parents some support because it's going to be a very difficult diagnosis for them to hear about. We would continue with folate, but we would avoid any unnecessary iron therapy. If he goes to the GP, they found him to be microcytic or whatever, they don't need to give him any iron. We're going to plan and counsel the parents for what's coming, which is regular transfusion regimen, maybe starting around 6 to 12 months of age when they have an indication to treat, which I will ask you about in a second. What are the indications to treat? Of course, the other things are coming as well. We will just give them a heads up, like chelation and growth monitoring, endocrine, psychosocial support. Also, a little bit about the curative options that are coming up. We will briefly mention to them, and I will ask you what those are in a second as well. So they are 5 months old now. So up till 4 months, she was doing okay, but then she slowly fell off, overfeeding, irritability, mild hepatosplenomegaly on exam, and growth velocity slowing. We have done a basic test and hemoglobin 6.9 on 2 occasions. Ferritin's okay as expected. FRCPath just confirms this is thalassemia major. So what do we do now?
Now she need to start transfusion.
Hmm. And what's the indications to transfuse? How do you see when to start transfusion in thalassemia, transfusion-dependent thalassemias?
Failure to thrive, organomegaly,
Yeah.
like signs of extramedullary hematopoiesis.
Mm-hmm. Very good. Or excessive intramedullary hematopoiesis causing problems. So there's a lab criteria and there's a clinical criteria. Lab criteria is anemia on 2 occasions, more than 2 weeks apart, just 70 is their guideline cutoff. And clinical criteria, irrespective of hemoglobin, if they are very symptomatic with anemia, failure to thrive, they are going to require transfusions. We know they have beta thalassemia major, but we're just trying to see, start when it's actually needed. So these are some of the reasons. We do not want to go here, so we pick up here and try to start. And it's not a walk in the park. They're only 5 months old or so. You have to plan lots of things, including lines and things like that, and the support around. Parents need to take time off and things. So it's not just a one person thing. So the whole family gets it needs support. What are the transfusion targets?
In thalassemia, it's supposed to be 140 hemoglobin.
140 pre or post?
Post.
Pre-target is about 100.
Post. Breeze 100.
Yes, yes. So we basically discuss mainly focus on pre targets. That's how but yeah, there is a role to see what the post targets can be. So the pre target, as you said, is we keep it between 95 to 105. That's the guideline quoted. We give transfusions every 3 to 5 weekly, but we consider a higher pre-transfusion target like 110 and 120 in some circumstances, like if they've got heart disease, which we think is from anemia, clinically significant extramedullary hematopoiesis, or inadequate myelosuppression at lower HP. So they seem to have still ineffective erythropoiesis happening, causing intramedullary problems like fractures and stuff like that from there. And of course, there are some transfusion requirements. You have to do baseline extended phenotyping or genotyping, especially if they've been transfused, and we match blood for ABOD, but also extended markers as well as we normally do for any patients who require long-term transfusion, but this is specifically true for hemoglobinopathies. Okay. Then we also, because we're starting with transfusion comes the risk of iron overload. So we will make a plan about monitoring iron overload as well. So we'll do ferritin every now and then, and imaging. So imaging, as I said, baseline must be done by 8 years or earlier. Earlier if it's needed. This is because again, it's not a walk in the park for a kid. They cannot lie down in an MRI machine, so you have to sedate them if you need them round about before 8. After 8, you can manage, or round about 8. It just depends on the kid, on the patient. And the two scans that we use are liver MRI and cardiac MRI to rely on. They are much better than ferritin. So liver, there are two options to do, either an R2 scan, which is a ferri scan, or just the other T2 star. Guidelines, our guideline quotes both the chelation guideline, but in evidence and literature, the R2 or the ferri scan is much better for liver. And even I've seen many experts, when they do get an MRI done of the heart, it gives you a value for the liver as well, but they still wait for a ferri scan to see what actually their iron loading is. And you have to be consistent as well. So, you have to follow the same investigation. So if you started treatment or monitoring based on a ferri scan, you cannot swap to a T2 star MI next year. You have to continue monitoring with the ferri scan. Also, ultrasound, liver and things should be done for monitoring cirrhosis and SCC when they grow up. And of course, endocrine monitoring needs to be done, including all sorts of hormones. For diabetes, of course, we cannot do HbA1c. Gold standard is OGTT, but you can do fructosamine as well. Why can't we do HbA1c? That's obvious. Hemolysis and transfused blood, but OGTT is better. Fructosamine does not depend on the glycosylation of hemoglobin, but it is actually a marker of glycosylation of albumin. So albumin is patient's own, so you can check that. Caveats include if they have had nephrotic syndrome or low albumin from other reasons, then you are going to have falsely low levels. Very important to keep, and so this is very important to make sure how the puberty goes, and the other hormones. They will check annually as very nice table in the iron chelation guideline. You can actually use that guideline to run decent clinic. Routine cardiology reviews start by 16 years of age unless previously necessary before that, and bloods as you know, would be done some monthly, like routine LFTs and things. Annually, virology is annual, and most of the hormones are annual. What are the targets that you use? Now this was a question I asked in the question as well. So, what are the targets you use for iron overload or iron chelation for ferritin and for MRI scans?
So, well, MRI for the liver, if it is more than 5 milligram per kg dry weight,
Mm-hmm.
and for the transfusion-dependent thalassaemia,
Yeah,
iron 1,000 a target, less than 1,000
ferritin, you mean? Yeah. Mm-hmm.
creatinine.
Yeah, yeah.
And the non-transfusion dependent is 800 creatine.
Yeah, as I said previously as well, for non-transfusion dependent, there's a slide coming. Actually, this is coming up next. So they're not very reliable in non-transfusion dependent thalassemia, the ferritin, especially once iron overload develops. How about cardiac, Amani? Cardiac,
Cardiac, we need it more than 20
yeah,
milliseconds.
yeah. So yeah,
Once it less than 10, this is indication for heart failure. So 10 to
yeah,
20, we need to start.
exactly.
Yeah.
Yeah, that's good. So ferritin, we aim for a target of less than 1,000. Less than 2,500 correlates well with low cardiac iron overload, but still cannot be relied upon on its own. Definitely need an MRI scan. Trends are more useful than individual values, but if it goes above 3,000, then you don't know what 3,500 means or 4,000 means. Very more in at such a stage, because it can be variable, and some liver damage can give you ferritin as well. That's coming on just because of liver damage as well. So if it's going down, maybe useful, but if it's going up, maybe not so useful, as long as liver and cardiac MRI are okay. Of course, as you know, it can be falsely up in acute inflammation. Um, Underestimates iron overload in NTDT. So iron overload, once it develops in non-transfusion dependent thalassemia, you cannot rely on ferritin. If at baseline they've never been transfused and the ferritin is more than 800, this is a good indication to confirm that they have actually got iron overload by doing MRI scans in them. MRI liver, as I mentioned, FERI target ideal is less than 7. 7 to 15 milligram per gram dry weight. Increased risk of cirrhosis is there. More than 15 means that now it's time for the heart. So have to keep it below 15 as a bare minimum. Or maybe and ideally for things like if you're going to become pregnant or things, then ideally you want less than 7. Or if you have previous serious complications, then less than 7. In the liver. Cardiac is by T2 star. Target is more than 20 seconds. If it's less than 10 seconds, as exactly as Armani's mentioned, so it's risk of acute heart failure. It's so bad that if it's less than 6, there's a 50% chance that a person will have heart failure in the next year. So that's why these are important, and you monitor them every 6 monthly to a year, depending on where the value lies. Okay, so this baby is now 20 months old, and the ferritin is 1,500. What to do now? They've just been managed with transfusion so far.
I think
We need to start
calculate.
ion chelation
Very good. Which one to start?
because he's below 6 years. We need this one.
Okay, one at a time. Amani.
Below 6 years, we need to start intravenous or
Yeah.
subcut dysproxamine.
Yeah. Pediatric hematologists, yes, know this very well. So as you do, so yes, so desferrioxime, deferasirox, and deferiprone are the 3 ones, and less than 6 years, definitely less than 2 years. The only option is deferrioxime, as per the guidance, because we don't have enough evidence for the other ones. So what plan do you give him? So what do you start him? So they are 20 months old now. So you start them on IV or subcut deferrioxime, and then after 6 years, after 2 years, there's an option, second line option with the guidelines code, but you have to be careful with the licensing and things. Guideline code you can use if there are compliance issues, then it's better to give them deferrasirox at least. rather than leaving them off any iron chelation. After 6 years, all the options open up, including deferriprone. If needed, you can give a combination at a later stage as well. But of course, when they're younger, they're unlikely to require combination because they'll not be significantly iron overloaded by then. And this is a very important slide. This is they're going to test you on this by various mechanisms, but this is also important for clinical real life as well. There are three main options: deferrioxime, deferrasirox, and deferriprone. Deferrasirox comes in a dispersible tablet form and a film-coated form. The film-coated form has got much better absorption, and it's a newer one. So if you are changing between two formulations, the dose is different as you can see. So the film-coated one, you can give lower doses compared to the dispersible. We are more commonly using the film-coated one now. Anyhow, deferoxime is subcut or IV. Both other ones are oral. Deferrasirox is once a day, so very convenient. Deferriprone is 3 times a day, so a little bit of a problem because this is going to be taken basically for life. Doses I've mentioned here, and you have to know these doses because they can ask you. Because say for the question that I gave you, you need to know what dose to start them on. In the scenario where they have heart failure. Now, how do they work? They work by chelating, so combining with the iron, and then that complex of iron and the drug is excreted in the liver or through the liver or the kidneys. So deferoxime has now got a very high tissue penetration. So it basically works it's actually, if you just give it as a bolus, it will be cleared by the circulation quite quickly. So you need a constant supply of that in the blood for it to work. That's why if you see, you give it over prolonged periods of hours, and if there's any emergency, you give it over 24 hours. As opposed to that, the other tablets, they can actually go into the tissues as well. Deferriprone has got very good heart penetration, so that is very important to know. For heart overload, deferriprone is a good idea, and usually used in combination with others in that sense. Key advantages with deferoxime is that it can be used in pregnancy. Others haven't been tested yet, but there have been pregnancies on them, and they have not been leading to bad consequences. But in animal studies, both of them are teratogenic, so we don't use them. Pregnancy only, we can use deferoxime, and that too usually starting after the first trimester. Main limitations, as you can see, a pump. How are you supposed to carry a pump? That's a problem. Deferrasirox and deferriprone can upset the stomach, but deferrasirox is renal elimination. So less than 60 creatinine clearance, you reduce the dose. Less than 30, you avoid it. And deferriprone specifically, problem is neutropenia, as you know. So you have to monitor the neutrophil count, especially when you're starting it. Some people like to monitor every 2 weekly for 6 weeks or so to make sure they haven't dropped their neutrophil count. It's like 2 to 3% of people develop it. It can be quite bad. Both of these, the first ones can cause a year-end eye problems, and that's because there are other metals required for functioning of the cochlea and the retina, and these are just chelating agents. They can chelate them as well, and this especially happens if you are over chelating them. So if there's not enough iron to chelate, they'll just chelate other metals. Ages, as we discussed, so less than 2, only option is this. If it's more than 2, you can consider that second line as the guidelines suggest, but have to be cautious with licensing and stuff. And more than 6, all the options open up. Yeah, as I mentioned, pregnancy, this is the safest, but others are contraindicated.
Husnain, what is the role of vitamin C?
Oh, yes. So vitamin C helps deferoxime. Basically because vitamin C apparently makes the tissue iron come out into the blood, so it moves the tissue iron out, and this can help. If it comes out in the blood, then deferoxime is circulating in the blood, and then it is going to be better able to catch that iron. Deferoxime, yeah. What's the chat about the spelling going on in the It is deferoxime, right? So I don't know. Anyhow, we actually call them
It is the
desferal.
same. Sometimes we are
Yeah.
calling this, sometimes we are calling this Thalassaemia.
Yeah. So this is the
I
standard
would
one, the
ignore that,
IV.
don't worry.
Yeah. So I'm like, oh, what's going on there? Anyhow, so yeah, this is problematic in terms of subcuttile IV, but only can be used in pregnancy. Extiate is really, deferoxime is very good because got balanced, iron chelation used only once a day. Problem with kidney function, if you keep, one side effect is developing Fanconi disease of the kidney, the renal tubular acidosis, not the Fanconi anemia. So, and deferiprone is very good for the heart. Problem is low blood count and the age group. Okay. Now, the baby is, how old are they? Let me check. So, they turn around 2 years old now. Anything specific to discuss? I think we'll have to move quickly from here. So anything specific to discuss? It turns around 2 years old.
The gross parameters.
So everything you're going to do, this will be a comprehensive MDT care, monthly or 3 monthly follow-ups and annual reviews or whatever. But anything specific to discuss around about this, Mark? We would have discussed that in the beginning as well. But
Stem cell transplant.
yeah, so people, stem cell transplant is curative. Best results are with HLA-matched sibling donor. This was the first child, so maybe they have had another pregnancy by then, and we would actually counsel the parents, if you do have another baby, plan to have another baby, let us know for various reasons. One of the reasons is that they can store cord stem cells from that delivery, and that could be an option for transplant for this baby in the future. But anyhow, it's very good cure rate with matched sibling donor, but ideally done in early childhood, less than 7 years of age, before significant iron overload develops. I know some centers like to start this process after 2 years of age, so they would like to transplant them after 2 years of age, and I've seen them do that as well. They do go down other routes as well, other donors as well. But anyhow, for exam purposes, this is what you need to know. She doesn't go ahead with transplant because there is no matched donor, basically. Okay. And then day 12, turn 12 years old. Oh my God, you've given the answer away. What do we discuss now?
The gene therapy.
Yeah, it says that. So yeah, it's potentially curative. The available on NICE is through managed access is XSL, but the caveat is when transplant is also suitable, but donor is not available, like for her, and they have to be 12 years and over. What we use is we use a CRISPR-Cas9 technique. So basically, what we do is we inhibit the BCL11A, and its inhibition, this is actually what makes the HbF stop, the gamma chain stopped being produced when you're about 3 to 6 months. And if we stop this switch, then the inhibition of HbF doesn't, the gamma chain doesn't go ahead, so HbF remains there, and a person would have increased HbF percentage, and you will see benefit to mitigate the thalassemia or sickle cell. Okay. Now they turn 16 years of age, and they've been on regular iron chelation since when they were a baby, with good regular transfusions with good compliance and good iron chelation. By 16, it gets too much. They become poorly compliant. They can't do anything with their life. It's such a big burden on them. Yeah, they don't go ahead with gene therapy, of course, as well, for whatever reason. But anyhow, and now they cannot just tolerate it. It's too much to ask, so the compliance goes down. 18 weeks, or no, 18 years of age, they present to A&E. So they are coming for transfusions every now and then. Maybe they're having some chelation, we don't know. But they present to A&E with 2 week history of back pain, progressive weakness of the legs, both legs, but more on the right, and unsteady gait, and problems passing water. So what's happening now? There's no trauma and anything else. So thalassemia talk.
So extramedullary hematopoiesis,
Very good,
fine
yeah.
compressing cord.
Yes, so
Likely.
that's what they have, and the examination supports that. So how do you diagnose it? You do an MRI scan. An MRI scan shows that they have got masses around T10, which is the most common region, gives you cord compression, but the vertebra will be preserved, so there are no lytic lesions or cancerous lesions there. So this is a good diagnostic point. We do not plan a biopsy because it's too risky, but we know that this is likely what it shows on there from the history and from the imaging. We discussed them with the right people, and some supportive treatment is given. But now we get really serious with the transfusion. We increase that pre-transfusion target to what I mentioned in the previous slide, and now controlling and doing strict iron chelation as well. More important than all of that is psychological support. You should already be doing them, giving them official psychology, support. But if not, then now is the time to do that. And this is more important than anything else over there. And this exam is definitely going to carry marks as well. Now, you guessed it, he's 25 years old, but he restarted iron chelation and transfusion, but better now. And they recovered fully from the cord compression. Now expects to conceive in 2 to 3 years. So what are the most important points that you want to ask them or assess them for in 3 headings, so to say?
Partner screening,
Very good. That's one of them.
optimizing iron chelation.
Very good. Last.
Mm.
So contraception till then, because we
Okay.
want to have time to help her with iron chelation and things. And with partner screening, we'll also offer her peri-implantation genetic diagnosis, including because they haven't conceived yet, so we can give them the option of PIGD, which basically means you would do sort of in vitro fertilization and choose the embryo which is not affected severely if the partner is a carrier as well. Okay, and that's an option that we have to mention in the counseling, which this girl's mom didn't have because she was already pregnant when she came to us. And cord stem cells. So cord stem cells for her as well can be stored if she has another. So if this baby is normal, but she has another baby down the line who might have thalassemia or whatever, so this can be used for the sibling. Anyhow, I think it's good to mention. And now she's coming in. So we saw her in the clinic now with her. She mentioned the intention to become pregnant in a few weeks. So this is where she stands. We're giving a transfusion every 4 weeks. I'm maintaining a decent target. Previously, we used a higher pre-transfusion target, but then we lowered it down because things settled and it was getting too much for her. Don't want to risk other problems as well. And now she's only on oral deferasirox. What do these parameters suggest from ferritin, liver, and cardiac MRI? EF is okay for her. It's her baseline ejection fraction. So what are we concerned about from the iron?
Liver
Yeah.
iron.
Is it? Yeah, it's very high. Yeah. So it's very high to the extent that it's probably started causing iron overload a little bit in the heart as well. So more than 15, as you know, risk for heart goes up. Ferritin is up as well, but anyhow. So other than that, they are doing okay. The borderline fasting glucose, but no other hormonal problems. They had puberty normally, so we didn't need to induce puberty in them because the iron chelation was very good when she was under peds. Infection screening is all okay as well. No significant alloantibodies. I've just said that for the sake of simplicity. Of course, as you know, a very high risk of alloimmunization here. Now, what's going to happen next? So yeah, actually, what iron chelation do you want to give them? So you've seen these parameters. So she's only on deferasirox. So how do you treat her now? Iron chelation?
Combination with this fluoxamine as well.
Yes. Which one? Sorry. Which one do you
The
want to
IV
combine?
or subcutaneous.
So she's on deferasirox. Which one do you want to give in addition?
I want to give the parenteral one, the disfluoxamine. Yeah.
Yeah. And why is that's okay, but why is that your option other than combining with deferiprone?
Because this is absorbed well and it is most potent by decreasing the iron quickly, not slower.
Potency wise, I'm not sure if head-to-head trials have been there, but the oral ones are very good as well. We do not doubt them.
I mean,
And
it is quicker.
again, Deferiprone has got good heart chelation and is tablet as well. So you're right, you'll give patient both options. So we do need to combine now because it's quite bad, the liver, and she also wants to get pregnant. So we want to bring it right down below 7. So combination is the way forward. Options are to combine this, which she is tolerating, with deferiprone or deferoxime. And you monitor their MRI T2 scar every 6 monthly because this is too high of the liver. I mean, the fatty scan and the cardiac MRI as well, 6 monthly side by side. I would probably combine them with tablets because of compliance issues and other things, and see if it doesn't work, maybe go to the other injection. The injection is very difficult to take. And then we will give her, we'll explain these are our targets, but you have to stop the chelation 3 months before planning pregnancy. Our gonadal function, as I said, is already okay, and other MDT care has to be involved, uh, especially including psychology, but cardiology is going to be very heavy involvement in her pregnancy because of her iron overload and the history. Okay, so
So, Dr. Hussein, for the pregnancy, I will leave them without any iron chelation, or
so
like 6 months,
this
3 months
is
before on
so
first trimester.
yes. So 3 months
Mm.
before, ideally, if you're not worried, then you 3 months before you should leave it. You should stop it. But as you know, deferoxime is okay in pregnancy, but we still prefer to not give anything in the first trimester. That's why we want to heavily chelate them so that the iron markers, especially the liver, comes right below 7, and the T2 starts more than 20 milliseconds. So if we achieve that, we will stop 3 months before. But if we are struggling, so say the liver iron is very high, still cardiac MRI is very high, etc., iron is very high, then there's an option to leave them just on deferoxime, but that's not ideal. But this is the risk versus benefit. It's like anticoagulation, bleeding, thrombosis type of thing. But ideally, we stop anything. We want to stop. It's like hydroxycarbamide. We stop everything 3 months before. That's the ideal goal. We have got 3 years. She said 3 years. This is what she said. I want to become pregnant in 2 to 3 years. This is what we plan to do. But let's see what happens. She actually
Okay.
becomes pregnant in the next year, with an unplanned pregnancy. But she was very serious about the chelation, so we did quite well there. So can you hear me still?
Yes, we are
Yes, we
hearing
can
you.
hear you.
Yep. My slides are stuck. Oh, thankfully, I thought maybe the wipe was gone again. Anyhow, so ferritin is dropped nicely. MRI was done 2 months ago. T2 star is normal now for cardiac, and liver is 6 as well. So we've done very good in a year, surprisingly, because she's been very compliant. She feels well and she's got no cardiac symptoms, especially any palpitations. So what do the next steps? What are the next steps? So, as you can see, so they can make questions out of any part of this whole journey that we are discussing, and they can easily give you a long essay on this. So now she's pregnant, and what do we do first of all?
Stop chelation.
Yeah, we stop the chelation because there's good enough control now. We reassure her and we monitor the fetus as well closely. We would refer her to the MDT now at Hemops unit in an HCC under the guidance of an SHT if he's already not there. Follow-up is for as high-risk pregnancies, 4 weekly till 28 weeks and 2 weekly afterwards. And then these are the 4 things that we need to sort out now for her in pregnancy. So imagine if you're seeing her at booking visit now. So I've already given you the headings. Just give me what you would suggest for them in a line and targets wise. And yeah. So transfusion, what do you do now? How much do you maintain the hemoglobin? So you increase the pre-transfusion to more than 100. So it previously was 95 to 105, but we want more than 100 now to support her and the baby. Iron chelation targets are the same. Liver is, we will monitor her. We can do MRIs in pregnancy as well, but we've got a recent MRI, so we are happy that hopefully we'll be fine. Endocrine, all the aspects need to be sorted out, but especially diabetes because of its horrible consequences in pregnancy. And you will do an OGTT or a fructosamine as I discussed. And then, what about supportive medications? Which one do you start?
Imsaparin.
Yes, you mean, yep, low molecular weight heparin can be considered. If they have got high thrombosis risk, then as per the other RCOG guideline risk factors as well, like smoking or high BMI or whatever, then they might qualify for throughout the pregnancy. But otherwise, if they don't have, you follow that. If thalassemia is the only reason with no previous thrombosis, then you can consider after 28 weeks and things as well, up to 6 weeks. But if they have splenectomy, then they are high risk, so you give them throughout pregnancy. So this is the caveat. So you consider low molecular weight heparin and you apply as per the guideline. Anything else?
Aspirin.
Yeah, aspirin is definitely must. We need to give a low dose 75 milligrams. And then lastly, folic acid, of course, is good for various reasons, which you should already be on. Yep. Then, what are the indications for transfusion in pregnancy? Of course, for transfusion dependent, it's obvious. You keep the hemoglobin above 100. For non-transfusion dependent thalassemias, you would, if they're untransfused, you can try to see if they can remain untransfused unless their hemoglobin drops, around about 36 weeks, which is the targets that they mention in the guideline. But if they have had any complication, maternal or fetal, you basically revert to being like a transfusion-dependent thalassemia. So keep the pre-transfusion hemoglobin more than 100. Postnatally, you transfuse as the non-transfusion ones as required, but of course, TDT will remain on transfusion throughout. Good. And then she is at 20 weeks now. Anything specific to check? So, of course, she'll be seen 4 weekly. Now she's at a 20 weeks check. Anything specific that we want to check other than the usual care that we mentioned? Anything specific that we
Virology
need to think
screen.
about? Yeah, that's
Viral.
been done at the screening visit as well. Anything specific, like from a hemoglobinopathy side of things, we need to see for her. The baby side of things, the screening side of things, are running side by side. I'm measuring from the patient's mother's side of things. So at 20 weeks, as you know, we can think if we wanted to start chelation, we were going to start it. So the indications for treatment include is given in the VSH guideline. If they're not already on, it's the same. So T2 more than 20, only give if the liver is also a problem. But if MRI, a cardiac MRI shows otherwise, then you start. And this time you start them on a lower dose of desferrioxime. And I see where the question, the spelling issue was coming from. I've always called it deferoxime. But anyhow, I think there's a variation in the spelling. Okay, so if it's between 10 to 20, the cardiac MRI is individualized. So for her, if she was between 10 to 20, we would give her because of previous history of very severe overload in the liver. Now, she is in labor and delivery. So where should the labor and delivery happen? At the HCC under the guidance of SHT. What else do we want to do specifically for her labor and delivery? So delivery would be as per OBS indication, the route and things. But what do we want to do from our side of things for her labor and delivery?
To optimize her hemoglobin.
Yes, so we've done that. She's TDT, so she's on transfusion to maintain her hemoglobin more than 100 throughout pregnancy. Good. What else? Chelation wise, so the guidelines suggest that we start deferoxime and we just continue throughout the labor, because in labor sometimes they've seen that the stress of the labor can release iron radicals into the bloodstream and they can cause acute problems. You just continue that throughout the labor till discharge. Cardiac monitoring of the patient if they have any symptoms, and active management of third stage of labor to minimize blood loss is also important, because you don't want to keep transfusing them. Now they have a baby as well. They want to breastfeed them till 6 months. What are your concerns, or what are you going to be for her? Transfusion is
I
continuing.
need to know whether the iron chelation is safe with breastfeeding or not.
Yeah, that's what they asked you. So yeah, that is true. So same goes as for pregnancy. The only thing that you can use is deferoxime or desferrioxime, whatever. And you will use deferrioxime throughout labor till discharge and up till they want to breastfeed. And if they want to, and you would do an iron assessment again at 3 months if you've not done again, because it would be due anyway. You can, as I say, you can do MRIs in pregnancy if there was need for it, but it's tricky getting a pregnant lady to have an MRI. And then if plans change about breastfeeding, then till discharge, till you continue that, but you can just revert back to their oral chelators afterwards, which they normally were on. So that's the journey of this lady from birth till giving birth. And they can quiz you on any of these scenarios and make a long essay out of it easily. And as I said, it's not been asked about in the last few exams, so I think it's very important to go through all the guidelines for thalassemia closely for the exam and for journal purpose as well. So that's all for today. Any questions? And I can stop.
You said iron chelation is safe with breastfeeding.
Just as ferrioxide is safe till with breastfeeding, and you will give her something. You've not given her anything for the full duration of pregnancy. You want to start it as soon as possible. So in labor, you will start her. If he wants to continue breastfeeding, desferrioxam will be the only option. If he wants to stop breastfeeding, then you can start the oral chelation. Desferrioxam would start at labor and continue till her discharge, because that's mainly because you can just in hospital you can run the drip. At home it's at the mercy of the patient. So if they feel comfortable, they will do it or not. But in hospital, we will offer them this throughout 24 hours. And the reason for 24 hours I've mentioned is the more it remains going in the circulation is how it works, because otherwise it quickly gets cleared from the circulation. And once they're discharged and they still continue with this, if they want to do breastfeeding, well, as soon as they want to come off breastfeeding, you can revert back to the oral chelators. Okay?
Yeah.
Good. Go through these guidelines, and that's all. Any questions otherwise, Amani, or otherwise?
Will
Thank
we
you so
get
much.
question? Oh, sorry.
Yes. Sirijit, please.
Will we get questions regarding HP electrophoresis charts and or like to differentiate other
Yes.
hemoglobinopathy
Yeah.
conditions and
Yeah. So as I said in the beginning, I thought shall I include them here, but this would have, because this was like an introductory lecture, so this would have been very complicated and it would take hours on its own. So what I think I would do is I will send some reading material first, and then we will do a small session maybe after the mock that is on week 7. And because I'm not preparing anything for the mock anyway, so I might as well just prepare like a hemoglobinopathy electrophoresis, interpretation with some good cases which I have in there, and then we can discuss them. And in that, we will discuss the other delta, beta thalassemias and HBEs and all of those things, because I didn't want to complicate things. Today, the aim was to focus on alpha, beta, and the guidelines, because I think they might ask you in long essay with beta thal or alpha thal or something like that around chelation or pregnancy. It's not been asked recently. Hope that helps.
thank you.
Anything else? Very good. I will stop there.
Hassan, I wanted to ask about the feedback for the previous
Oh, yes.
section and the
As I
answers.
said, I was very busy. And
Okay,
I
no
will
worries.
try to do that this week. I've got more time this week.
Okay, no worries,
And
whenever you are free. And
yes.
today's answers also, maybe
Yes,
those
I've
who have
seen that
submitted.
you've just sent as well, and some other colleagues have sent as well. Those who haven't sent, you should definitely attempt the exam now. As you've seen, I've not discussed heart failure from thalassemia in this guideline, in this presentation on purpose, because I want you to do it. So, and then I will send you the answers. That makes sense. So I will stop the recording now. If anybody else wants to ask a question off the
And
screen.
what are we doing next week?
Sickle cell, I think. Yeah.
Sickle, okay.
Yeah, I'll send you as usual. I'll send you the resources to go through, and maybe tonight or tomorrow morning.
So for this baby, his name, we check the chorionic blood,
Sorry?
or for this lady,
Mm-hmm.
we know her, she has beta thalassemia major. But when she's pregnant, we will do also for the baby the chorionic sampling, or
So
we will do the
she's got beta 0 beta 0. So
Yeah.
definitely need to screen the partner, as in the father, not the partner, the father of the baby first. If the father of the baby has got no problems, they haven't even got a thalassemia trait, then baby at most is just going to be a carrier. So we don't need to do invasive testing for the baby. But if they are also a carrier or affected by thalassemia, then depends what they have got. And then if they are a carrier, for example, with beta thalassemia trait, then you would do the same thing. So you would do the coordinate between the sampling or amniocentesis, or at least offer it to them so that they can make choices. As for her, when we discussed when she was a baby.
Yes. Yeah. Thank you.
Okay. Thank you very much, guys. Have a good day. Take care.
Thank you for watching. Stay tuned for more.